I'm Jeanette Potts, and I am a office-based urologist, and I specialized initially in family medicine, and then I was invited to do a special fellowship under the tutelage of Andrew Novick at the Cleveland Clinic, and actually the entire staff. I owe it to the entire staff of the Glickman Urological Institute for my fellowship training. And in doing so, I was the gatekeeper for the Cleveland Clinic for all things urologic. And I'd work those patients up and had two busy outpatient surgery schedules per week. But eventually, it became clear to me that there was a void in terms of the care of men who had what at that time was called chronic prostatitis. And unfortunately, that was many decades ago, and we continue to use the wrong terminology. So that's why I'm going to start this talk off with this very old slide about the urologist saying that he'll gladly write a prescription for an antibiotic once the patient lets go of his finger because of his tight sphincter. And actually, the joke behind this card is actually in part the reality that perhaps we're not dealing, or actually most of the time we're not dealing with an inflamed prostate. We're dealing with problems in the pelvic floor and sometimes even a more global issue that's not even urological. So let us begin. So the name of this talk is, can we handle the truth that male urologic chronic pelvic pain may not be urologic at all? We have all these names and all these terms used for the symptomatology of the disorder. Men describe ball pain, groin tenderness, sitting on a golf ball, etc. I just want to let you know that my disclosures are our practice, Vista Urology in California, and that I was a member of the NIH Prostatitis Collaborative Network. I was also a member of the Giessen Consensus Panel on Prostatitis and Pelvic Pain. As I alluded to before, I was Dr. Andrew Novick's Frankenstein monster. He was the first to create an office-based urologist with a procedural bent. And most of my CME comes actually from my patients, because there is really no other way to learn about this phenomenon other than the prostatitis or prostatocentric literature that's out there. So most of the things that I've learned is by listening to my patients and exploring their symptomatology and exploring their observations. So let's first begin with a brief lesson in taxonomy. Let's assume that there is a National Institutes of Health encephalitis classification system in which category 1 is viral encephalitis, category 2 is bacterial encephalitis, and category 4 is an asymptomatic form of encephalitis just with an abnormal CSF. But category 3 is a headache. Imagine if we treated all patients with headaches as if they had encephalitis. Well, that is absurd, and fortunately, such a classification system does not exist. However, this classification system has existed and continues to be perpetuated in our lexicon. The NIH classification system for prostatitis has category 3 as chronic pelvic pain syndrome, and this actually represents 95% of the patients. And this is not even a diagnosis. It's just a constellation of symptoms that get placed under a prostatitis classification. Imagine if we were dealing with chest pain and everything, had to do with gastritis. Or imagine if everything had one category or one classification, and the most general and most non-specific symptom was then placed under this category. So my first truth is that these problems in men are not prostatitis. Maybe in 5% or less it is, but 95% of the time, the patients do not have prostatitis. And again, I want to emphasize that there really shouldn't be a designation of bacterial prostatitis or abacterial prostatitis. Prostatitis should just be reserved for people with an infection, a bacterial infection, period. And that's 5% or less of the patients. We used to look at the express prostatic secretions and count the white blood cells. And we did find that eventually this had no correlation with bacterial prostatitis episodes. It had no correlation except perhaps in acute prostatitis. But other than that, the leukocytospermia or the abnormal EPS, that can be seen even among asymptomatic patients, which I showed in 2000 after examining over 140 patients. Histologically speaking, we identify prostatitis a lot on biopsies and also on TURP specimens and prostatectomy specimens for cancer. But nevertheless, most of these patients are not even symptomatic, and there may not even be a clear history of whether they've ever suffered from prostatitis-like symptoms. Histologically speaking, we know that among symptomatic patients, only 5% had inflammation on their biopsy specimens, and this is among younger men. And among asymptomatic patients with elevated PSAs, we see it in 52% of patients, or at least that's what I've shown. And I've also seen this looking and reviewing other histological samples. So we used to do the localization cultures. I still do these in my practice, mostly to assuage the anxiety of the patient and to, help them break the cycle of recurrent use of antibiotics, or what I like to call the antibiotic addiction, which used to happen a lot more. But there was an addiction between the physician and the patient, both needing to do something and needing to take some kind of drug, and both thinking that this will make them feel better. We also now know that the significance of bacteria in the EPS is not really clinically relevant. Only 5 to 7% of patients with pelvic pain have positive bacterial cultures, but controls who are asymptomatic also have the same rate of positive bacterial cultures. So we need to be very cautious about when we give antibiotics, because even when we do have a localization culture, it may be prudent to repeat that culture to ensure that it is in fact a bacterial infection localizing to the prostate. But remember that category 3 prostatitis has never proven to be caused by an infection, nor has ever been proven to be a disease of the prostate. And that was the fine print of this classification system that was proposed in 1996. And sadly, we still see it cited in current articles. Well, in the late 90s, I was invited to an NIH meeting, and when my colleagues were presenting all of their work on interleukins and cytokines and nanobacteria and all these, caustic framework of men's semen and prostate, I drew this slide and presented it on an overhead projector. That's how long ago that was. And I felt that the prostate was being framed, that this was just the wrong way to approach men with these problems. But we still call it urologic chronic pelvic pain syndrome. So we have to be very careful about how we, again, use words. So the urological differential diagnosis would be, outlet obstruction, which could be BPH or benign prostatic enlargement, bladder neck hyperplasia or dyssynergia, or stricture disease. Urinary calculi, these can occur in the UVJ that can cause some urgency frequency and referred pain, bladder calculi, or urethral calculi. Infections can certainly play a role, but as I said, for prostatitis, it's 5% or less. And there are times that we should be looking for STIs and certainly making sure that people don't have any other underlying infection. Neoplasm, it's rare, but sometimes metastatic urologic cancers or other pelvic cancers can be manifest with pain. And ischemic episodes, they're more acute, but like testicular torsion and organ infarction. But often, very often, the cause is not urologic either. So this is how I look at pelvic pain syndrome, as a myriad of other conditions. Oftentimes they're even overlapping. So there could be neuropathic pain, which could be discogenic, it could be peripheral. There could be functional somatic syndromes, which are more correctly termed central sensitization syndromes, myofascial trigger points, psychosocial factors that are exacerbating, and again, the infections or urologic conditions. But a lot of these overlap, and I have the sizes of the circles representing how common these disorders are and how often they do overlap. In order to decipher these causes, it's important to get a good history and know the patient. What is his work situation? Is he sitting a lot? Is he in a stressful work environment or even commute environment? A sexual history has to be taken in a very sensitive and comfortable way. We need to understand what the person's sex life is like, and if there are any issues, stressors, or changes in that manner that may have been triggering or predisposing the patient. I often discuss pornography use, as many of my patients are using porn to have to perform edging, and edging, postponing the orgasm to heighten the effect, can sometimes trigger some of these pelvic floor issues and discoordination, if you will, of the pelvic floor. And it's not enough to just ask people, are you regular? Is there blood in the stool? Just the regular review of systems question. It's important to understand what the person's defecation is like. Is it painful? Is it complete? And is it satisfying? Because this is also part of the pelvic floor function and part of the pelvic pain dynamics. Oftentimes you will get a lot of clues from this part of the history. We also use the Bristol stool chart in our practice. And I use this to first ask patients where they're at the time of the appointment, and then counsel them about our goal in terms of bowel regimen, diet, and harnessing the gastrocolic reflex. Exercise and recreation are also important parts of the history, understanding if men are weekend warriors, if they're working out and perhaps using poor technique. I find that my patients are not in the middle of the spectrum of exercise. They're on either end. They're either on the very sedentary edge of the spectrum, or they're athletes. And many of them, especially in California, have encountered more and more extreme athletes. And a lot of their issues come from poor technique or repetitive use. And this is an example of a site for trigger points in yellow, and that's the psoas muscle. And in purple, we're demonstrating the referred pain pattern. So when I see patients complaining about discomfort or tingling or pain in these areas, I'm already trying to think about the spots I'm going to evaluate during the examination. And here we can see the adductors and their referred pain pattern, and the piriformis. And there are many, many more. So these are the types of things that you look at while the patient is walking to the office, walking to the exam room, and sitting and rising from the chair, and you start getting clues about this. This led to us designing a randomized multi-center trial to look at the feasibility of myofascial physical therapy for these patients. And besides showing feasibility, it actually proved to be very successful. However, PT, because of that paper, has now become the new Cipro, and that's not good. Because PT has become the new Cipro, physical therapy is being prescribed to patients in the same manner that ciprofloxacin was prescribed for many years. That is, without a physical exam, without evidence of an infection, or in the case of PT, evidence of myofascial trigger points or other physical or neuromuscular issues that are contributing to the pain. And furthermore, without the evidence, they're prescribing PT and then not even having follow-up. And that's exactly the same thing that would happen with the patients who were just prescribed 6 weeks of antibiotics over and over again without a follow-up, without reassessment. Oftentimes, PT may not be the only way to treat the patients, and there are times when other things can even be missed. The patients need a doctor. The patients need to have an exam, and the patients should always have their first pelvic examination performed by a doctor. It is not the place of a physical therapist to perform that first internal pelvic exam, nor is it the place ethically, morally, economically, whatever reason, it is not the place of the physical therapist to make a diagnosis either. And here are some cases where patients were seen by PTs, but they had other causes for their symptoms. This is a patient who had acute and chronic inflammation of the bowel, who was treated repeatedly for prostatitis and in fact had diverticulitis in his 30s. And what he needed was a doctor to make the diagnosis, and then I referred him for colorectal surgery. And we can see here that he has evidence of acute and chronic inflammation of the bowel and free air. This is a patient who had a colectomy in the past for ulcerative colitis and was sent to me for acute prostatitis because of all of the pain he was experiencing. Well, this man had prostate cancer with metastatic disease. And this patient was also being referred from urology for, again, pelvic floor PT. This was another patient who I initially had prescribed physical therapy, and he did very well. And then a year and a half later, he returned and said his symptoms recurred, but they felt different. And in his exam, I could no longer detect any myofascial trigger points or any tension in the pelvic floor. However, it also didn't feel right to me. So it was a rare time where I would get an imaging study. And as you can see here, he has a chondrosarcoma of the acetabulum, and he had to undergo a hemipelvectomy. This is a patient who had seen multiple physical therapists and multiple urologists in California. And when he came to our practice, I asked him to just stand up and show me, like, what is it like for him to pee, because that was also part of his symptoms. And he really struggled and thought it was normal, and was also suicidal because he thought that he could not follow yet another, the sixth physical therapist's regimen. During the exam, I used an ultrasound and got this image, and you can see a large bladder with post-void residual, thickened wall, and these are his ureters. Fortunately, his renal function was not compromised, and we ultimately diagnosed him with a very significant bladder neck obstruction due to bladder neck hyperplasia. The fifth truth is that functional somatic syndromes or central sensitization syndromes are common in UCPPS. In fact, I would say that this is the most common overarching diagnosis that I see. Functional somatic syndromes are a constellation of symptoms which are frequently persistent and distressing, and after appropriate medical assessment, they still cannot be explained in terms of conventionally defined medical disease. And this represents 40% of all consultations regardless of specialty, from medical to surgical subspecialty clinics. This is a significant part of it. Because functional somatic syndromes or central sensitization phenomena can occur as all of these diagnoses. And as you can see, among all of these diagnoses, all of the specialties are represented. And when I had initially seen this article in The Lancet in 2000, I realized that this was describing my patients who were seeking a second or third opinion for so-called prostatitis. So I did a quick review of over 100 charts, and I found that among patients seeking second opinion, almost half of them had a psych-related diagnosis, and 65% met the criteria for a functional somatic disorder. And that was just doing the chart review, in a retrospective fashion. So imagine now in my clinic where I'm doing this in real time, looking for functional somatic disorders, I would say that it's more in the 75 to 80% of the patients I see. And what is so remarkable about this is that the population lifetime prevalence for a central sensitization or functional somatic syndrome is only 4%. It's possibly as high as 8% in the female population. But this means that what we're dealing with in the world of prostatitis or urological chronic pelvic pain is not an end organ disease, nor is it a subspecialty disease. It is a global syndrome affecting all parts of the body. And that is why I think we're seeing this higher percentage, because the patients tend to have other overlapping disorders. After I had published this, another investigator reviewed the prostatitis database and found that if you were to take the chronic prostatitis patients and look at all the other disorders or symptoms that they had in other domains, it was significantly higher than controls. So again, these patients tend to have more overlapping diseases, overlapping symptoms, and overlapping types of syndromes or things that are unexplained. As I mentioned, the new terminology is central sensitization, and that's thanks to Dr. Eunice, who also is responsible from changing the term of fibromyositis to fibromyalgia. And in this cartoon, we see that there are multiple factors playing a role driving the predisposition to central sensitization, things like sleep, trauma, micro trauma, even all of the things like, that would be occurring or overlapping at the same time, stress. And some of this does go back to childhood neuroplasticity, things that may have been traumatic or predisposing the child to some sort of susceptibility as they grow older. Once the central sensitization is set in, it then feeds back into this same cycle. So it magnifies conditions, it prolongs conditions. And again, we can think of patients right off the top of our head where all of these things are at play. And if we look harder, we will find it in other people and be able to validate them and perhaps give them better tools for managing this disorder. And the way this happens, more so I think in the pelvis, is that we have an overlap of stimuli and different sensations coming in at the dorsal root ganglion. So if something is happening in the pelvic floor area or in the skin or in the muscle or in one of the organs, it comes through in an afferent pathway, and then like changing train tracks, it then goes up in the spinal column to the brain, and then the perception and interpretation of that pain then gets transmitted back down in an efferent fashion. Well, when that comes back down, it may be reinforcing that pain sensation, and it can magnify it. And over time, more and more geography, if you will, gets recruited. And that's why we see patients who perhaps 5 years ago, they had a hemorrhoidectomy, but when they're presenting to urology, they're having pelvic pain and they're coming to you because they have scrotal pain. But it turns out that all of these things had begun with the hemorrhoidectomy, and perhaps everything went perfectly well, but the patient was sleep deprived at the time, the patient was stressed at the time, or some other factor came into play. So this is why we need to think of pain as a two-way street and realize that the way we interpret pain in our brains has a lot to do with how pain is perpetuated. Let me give you another example. Let's say you're in your home and you're doing some handyman work and nailing, hammering some nails to the wall, and you hit your finger and it's a 10 out of 10 pain. It's immediate, it's acute, but your brain knows what happened and your brain just says, you're so clumsy, be careful. And it kind of shuts down the pain so you can continue the task. Well, that's your brain helping to attenuate the discomfort after its interpretation. But if there's the slightest irritation, a 1 out of 10, that starts to occur in an area that is highly innervated, like our sex organs, like our excretory system organs. So, and then we begin to worry, I had a friend who just had cancer, or someone I heard about had testicular cancer, or it feels like it's my prostate. My prostate is growing and I fear prostate cancer. Or I had sex with someone 2 weeks ago and I'm having this burning. What if that is the issue? Well, now the brain isn't turning off the pain. The brain is busy trying to figure out what that pain is, and it's fueled with fear. And so you can easily take something that is a 1 or 2 out of 10 that you might dismiss, and it can certainly over time begin to escalate. So this is a very important thing to consider when our patients are presenting themselves with a pain that we might consider something minor and we may be wanting to be dismissive. We need to validate our patients and understand how these things can escalate so that we can help them to decatastrophize, because catastrophizing is very common in this setting. The more recent MAP studies sponsored by the NIH have included pain mapping, exploring sleep disturbances, depression, and poor illness coping, really looking at this in the way that I introduced in 2000, that this was a global phenomenon and this central sensitization. And what they found was that 75% of the symptoms and pain that is demonstrated on the patient mapping is 75% of it is outside of the pelvis. They also find that there are many sleep disturbances coinciding with this condition of pelvic pain. And with increased sleep disturbances, there's an increase in the non-urological conditions. Depression also has a greater risk of centralization or central sensitization phenomenon. And of course, we know that these patients will have catastrophizing, poor illness coping, and a feeling of helplessness is also correlated to higher symptom scores. So this is corroborating with what those of us in the trenches have always known. And I just hope that more practitioners can embrace this framework. The impact of this phenomenon is really large. As I mentioned before, it can represent up to 35, I would say 40% of outpatient consultations across medical subspecialties. In 2005, this added up to $256 billion per year attributable to the incremental effect of somatization alone, because the patients have what I call the doctor du jour syndrome. They go to every subspecialist. It's not uncommon to have someone see me for prostatitis who has then seen a gastroenterologist for leaky gut syndrome, and someone else who's had non-cardiac chest pain, and someone else who has non-ulcer dyspepsia, on and on. And those are very old numbers. I mean, now it's even more expensive. And we also know that the patients as individuals have a greater healthcare cost, just comparing specifically patients with rheumatoid arthritis. And again, the cost difference between a chronic prostatitis or a pelvic pain patient and a typical HMO patient is all due to problems other than the prostatitis. Again, corroborating this more global syndrome. And as I said, it perpetuates the doctor du jour syndrome. So truth number 6 is that when we are dismissive, we are complicit in the cost. So if we were more willing to take the time to first diagnose the patient with a central sensitization and then counsel them about it, and then have resources for them to be treated, we would then stop this bleeding of money in our healthcare system for these patients, because they really need a lot of reassurance in order to stop seeking medical care. Now we'll begin the next section of my presentation with truth number 7. Patients deserve a thorough clinical examination. Both of my children are in medicine, and one is my husband's daughter, who's an OBGYN, and one is my son, who is a urologist. And when they were in training, I told both of them, don't ever stop doing physical examinations. Don't ever avoid a physical examination, even if the most famous colleague sent you the patient. Even if your chairman sends you the patient, always do the physical exam. If you're seeing your patient in follow-up and things are not going well, always do the exam. There is nothing more satisfying than actually being at the bedside, looking at the patient, smelling the patient, touching the patient, palpating, and making a diagnosis. Too often, people rely on studies. They get imaging studies too soon, and then people avoid doing the exam. And months or even a year can go by, and there are a lot of things that can happen that need to be reassessed. And also, reassessing your own patients keeps you honest and keeps you sharp. And I think that it really makes us better physicians, because we know what we can do better, and we refine. We're constantly refining and improving. So to that end, in some patients who are presenting with discogenic types of symptoms, it's important to examine the spine, put them in different positions, see if we can reproduce some pain and reproduce referred pain. I always check the lower extremities in these patients, especially those with pelvic or scrotal pain. Sometimes a simple orthotic will help. But, just assessing pronation, doing this as part of the mapping, if indeed I'm going to refer the patient to physical therapy. Myofascial trigger points are important to assess too. And with practice, one gets quite good at it, especially because they're often more pronounced on one side of the body than the other. So you can actually practice as you're learning to understand and compare. Usually can palpate taut bands, painful nodules. The area that is affected usually exhibits weakness. So you can see an asymmetry in the adduction at the hip level. There's limited range of motion. And sometimes we even are rewarded with referred pain or a twitch response when we hit the right trigger point. So think of it as a fuse box in the house, and you're hitting different fuses, and you can get some really distant, or some of them are nearby, pain reactions. And so this is my favorite muscle group. It's the obturator internus. And I usually test this internally through the rectum. And this is how I do it. I put the patients in lithotomy. I don't go this fast, by the way, but I check everything with my right hand when I'm doing the right side, and I check the left side with my left hand. And at the finale, I move the coccyx. The coccyx should move 1 to 2 centimeters without pain. Otherwise, the levators are probably really pulling on it tightly. And then the very last thing I do is check the prostate, because oftentimes patients can learn that the discomfort that I reproduced in their pelvis came from other sources. And then finally, at the prostate, I help them to differentiate what that sensation is like. It's uncomfortable too for many men, but that's normal. That's not prostatitis. All men are very sensitive when you palpate the prostate. And this is a image of the right hemipelvis from the inside. And here we see the path of the pudendal nerve, and we can see the branches that go towards the rectum, the perineum, the scrotum, and the penis. And so when I'm palpating internally, I'm very careful at Alcock's canal, but what I'm looking for is a Tunnel sign. And I will palpate just more medially and inferiorly and try to localize the pudendal nerve. And when I do this, sometimes I will get the pain reproduced. And so then that also helps me with my diagnosis. It's very common, like when men who have tingly sensations, discomfort in the penis, to have a reproduction of that pain or an exacerbation when you hit that area gently. And I also check for this confusable diagnosis. It's confusable with the pudendal neuralgia, and that is the posterior femoral cutaneous nerve entrapment or irritation. And you can see that it also innervates the back of the scrotum and the perineum, and it will become worsened with prolonged sitting and the similar types of risk factors as pudendal neuralgia. Now, I'm not testing for this to give the patient yet another diagnosis, because oftentimes the same types of treatments are going to be helpful for myofascial trigger point, pudendal neuralgia, and this posterior femoral cutaneous nerve irritation. All these things can get better together with conservative therapy, but it's important to know these separate diagnoses in the event that things are not getting better, and these patients may require, a series of nerve blocks or some other form of neuromodulation in form of medication, for example. So practice makes perfect. The more that we do these types of exams, the more sensitive we become, the more observant we become. So I really encourage this. I have to tell you about 2 recent deaths in my tiny cash-based practice, because it's really sad to think that we're surrounded by really wonderful medical centers, very prestigious individuals, but this is what happens when people don't get examined. Mr. H was referred from a tertiary care center for UCPPS after a negative surgical exploration and a negative CT scan. And he was, people just thought he was a kind of squirrely old man. And Mr. F was referred from a tertiary care center for prostatitis after an abnormal CT scan. Well, Mr. H, when I examined him, on the left side, he had a 3 by 2.5 centimeter firm nodule, a mass at left Alcock's canal. And this was what was causing his 24/7 pain and defecatory problems. The sad thing about Mr. H was that he had a prostatectomy many years ago, and his PSA was 0. And he also had a cystectomy many years ago, and his CT scan was negative, but that was 9 months ago. And no one really ever did a digital rectal exam on him, because why would you? He's got pain there, but his PSA is 0 and a CT scan was negative. So when I've lectured about this in the past, I always put up my finger and say, this little humble finger can beat technology in some cases, and we should never be dismissive of our most basic skills. Mr. F, when I inserted my finger in his prostate and he was in a prone position, I found a very massive right lobe and a seminal vesicle that was like a rock. And it turned out this man had metastatic prostate cancer. Phenomenal that, this man, just because he had pain, it's like this obvious prostate cancer was missed. And again, both of these patients had gone through the gauntlet at major institutions, both in Southern California and in the Bay Area. So, what if it is prostatitis? The patient would have malaise, fever, lower urinary tract symptoms, possibly retention. The urinalysis is positive. There's no doubt about it. There are organisms, there's white blood cells in the urine. You don't even have to do a localization culture. If the man is having recurrent UTIs with the same organism, this is usually chronic bacterial prostatitis. And if anyone is ever in doubt, they should do a localization culture and not use the antibiotics until the culture comes back. Actually, starting patients on antibiotics empirically and then withdrawing it after the culture just does not make sense. Unless, of course, the patient is sick and has a fever. Then empiric therapy is in order. Just always pause. If you're tempted to write a prescription for antibiotics, then it should follow that a localization culture is necessary. And again, I mean this in terms of the patient who has a normal urine, doesn't have a fever, but the temptation to still write an antibiotic is there. So if the temptation is there, then please start getting localization cultures, because that will help to make the doctor more reassured, and it will make the patient more reassured, and it will help stop the overuse and abuse of antibiotics. And again, this is just a little cartoon of getting the prostate massage. The Giessen consensus, which was published in 2002, asks us to get 2 corroborative localization cultures before subjecting a patient to 4 to 6 weeks of antibiotics. I adhered to that well before 2002 and long after. And I can tell you that initially, when I stopped using antibiotics in patients empirically, which was standard of care in the 1990s, I was really frightened. I thought I was going to have patients with urosepsis showing up, and I was going to be presenting my cases at mortality and morbidity conference. But it turns out that if patients are fine and you follow up and you get the culture, there is really nothing to be afraid of. We do know from another study done by Nickel with very large numbers of patients that the localization cultures were positive in 7% of both symptomatic and asymptomatic controls. So again, I think that this why it's very important to hesitate in giving antibiotics even when the localization culture is positive, and to try our best to adhere to the consensus statement from Giessen, where we need 2 corroborative localization cultures. I strongly believe that we will be better stewards of our antibiotics if we do this. Just as a reminder, to get a localization culture, one has the patient come in, preferably without having urinated in the past 2 to 4 hours. And when the patient arrives, they are given 2 glasses, 2 sterile cups. In the first cup, I instruct them to immediately void the first 10 to 20 mLs of urine. This would be the urine that is usually discarded into the toilet before catching the mid-void. So I want that first specimen. And then afterwards, they collect the mid-void as they normally would. During the examination that follows, I will do a prostate massage. And I have another sterile bottle ready for them at the time of the massage. And after I do the massage, I ask them to pee a little bit into that cup to rinse out any of the semen that was dripping out from the massage. And to help them out, I usually just turn the water on and leave the room so that they're able to produce that bit of urine. And then all 3 are sent for an obligatory culture. As you know, if you just send a mid-void urine, it's clean catch, it's a screen, culture screen. In this case, we want an obligatory and a quantitative culture done. And then in interpreting that, for example, if the The VB3, which is the one done after the massage, shows 1,000 colony forming units of E. coli, but the VB1, the first one, shows 1,000 colony units of E. coli. We know that's not prostatitis. We know that that's just the contaminants or living in the urethra that were taken through that specimen, but not localized to the prostate. A lot of times we are looking for a higher number in the prostatic specimen, and that's how that is interpreted. If patients are not circumcised, make sure that the foreskin is up, make sure that their hands are clean, and ask them not to have their skin touch any of the rim of the specimen cup. Sometimes you get some false positives with staph and other skin organisms. So that's how you do a localization culture. Oh, and by the way, sometimes you have to train the lab on how to do it. I thought that when I was in the Bay Area, because the Mir-Stamy technique, which is the localization culture technique developed by the former chair of Stanford, I thought, well, everyone in this area must know how to do it. Well, I'd have to go to the lab and train people how to manage the specimens, even at Stanford when I would send the specimens there. So when people say they do these, it's not true. Most doctors are not doing these. And the irony is that the doctors who do perform localization cultures are the ones who are least likely to use antibiotics. So let's talk briefly about another organism. I'm seeing or getting a lot of emails from patients who were diagnosed with a ureaplasma infection. Ureaplasma is a mollicute. It's in the family of these organisms that don't have a cell wall, so they're very hard to culture. And their relatives are also Mycoplasma, Mycoplasma hominis, Mycoplasma genitalium, and then Ureaplasma urolyticum. Many years ago, I did research on ureaplasma, and I did find that certain patients who had a history of multiple STIs and multiple antibiotic use, who continued to have symptomatic, and I couldn't find anything else wrong, they had ureaplasma. I treated them with doxycycline or zithromax, and they were better. Some were completely cured. But again, it was a very select population. I was not doing it globally, but I feel a little guilty for starting this trend with the ureaplasma culturing, because now it seems that patients are tested for ureaplasma without other adequate evaluation, and then everything gets blamed on ureaplasma. And actually, ureaplasma, for the most part, is a commensal. It's just an innocent colonizer of the genital urinary tract of healthy men and women. And so a lot of the patients are being overtreated with antibiotics. They're being misdiagnosed as having an infection as the cause of their symptoms. And even though the ureaplasma is detected, it's present, the cause of the symptoms are the other reasons that I've demonstrated in the earlier lecture. Oftentimes, or usually, these are not pathogenic. As I said before, I'm looking at like an abnormal flora because of past STIs, past antibiotics, and that is usually not the patients that are seeking a second or third opinion about this. Again, we have to emphasize that there are so many other reasons patients will have these symptoms, and we cannot just take a shortcut and say, oh, you have this, we'll just do a panel and culture you for mycoplasmas. So I strongly recommend not testing for ureaplasma, like really just stop it, unless you're a specialist in it and you're going to know how to treat it, because oftentimes after people are using doxycycline or zithromax or whatever, they then just put their hands up in the air and leave the patients hanging. Well, we don't know what else to do for you. So unless you've done a complete methodical examination to exclude other causes, stop the ureaplasma testing unless the patients had a history of STIs in the past and multiple rounds of antibiotics, again, because they might have an abnormal flora and therefore the ureaplasma could be in a high count and be pathogenic. Also, that you're willing to treat and follow up the patient. If you're not willing to treat and follow up with the patient, and that means following up and realizing it didn't work and then you have to do more and more, if you're not willing to do that, please don't test for ureaplasma. And finally, please obtain the susceptibility profile. Ureaplasma is currently highly resistant to standard antibiotic regimen. I wonder how that happened. Ureaplasma and the mycoplasmas now have a very high rate, like I don't know the current number, but it's greater than 50% resistance. So when I see patients who contact me saying, oh, my doctor wants to put me on 6 weeks of doxycycline because my first 3 courses of antibiotics didn't work, I just can't believe that's being done without a susceptibility profile, because now we're committing the patient to 6 weeks of antibiotics instead of 2, and we don't even know if the patient has a resistant organism. And furthermore, when I do see patients who have a resistant ureaplasma and they're completely devastated, it's not uncommon for me to find the cause of their symptoms and treat that and just have them learn to live with the idea that they're colonized with ureaplasma that's resistant. And then we just do other things too to help fortify their flora to keep the ureaplasma in a low count. So again, ureaplasma these days, it's quite the thing. It just seems just very fashionable. And to be frank, from what I've seen in the patient population that seeks out my opinion, I find a laziness on the part of their previous healthcare, because rather than asking certain questions, rather than doing a physical exam, doctors are just shortcutting and doing this, fancy test for ureaplasma. So anyway, that's my soapbox on that. And the final truth is that chronic pelvic pain is common and very challenging. So we have to realize that if we only come at it with one perspective, oh, this has got to be prostate, or if I'm a GI guy, oh, well, this must be irritable bowel, or, we really do need to take a broader look at the condition and look at the whole man, the whole person. And as part of that truth, we need to accept that there is no shortcut. When people request from me algorithms for this care, they're asking me for a shortcut. Certainly, there are bits and pieces of algorithms that do come into play when we're assessing the patient. However, the main message I wish to convey is that you just need to accept there's not a shortcut and go from there. Because if you keep wanting to fight for a shortcut, then you keep avoiding the care of the patient. So I would say that given the environment we're in now with the constraints in clinics, that perhaps the schedulers can just have patients with chronic pain have 2 appointments scheduled upfront, back to back. That way, everyone is not rushed and the patients can have a good history taken and then have the physical examination and treatment. Please be curious. It's not the same old thing every time. The patients are all unique, and a lot of what needs to be taken care of is not just physical. Patients need to witness your curiosity. The patients need to witness your formulation of the diagnosis. This conjures so much trust, and this is a very, very big part of their healing. Employ active listening as much as possible. Many years ago, I got rid of my wristwatch and I don't have a clock in my clinic. And I used to fear 20 years ago that I was going to be inefficient and that patients were going to take control of the time. And that has never happened. So don't be afraid to do the active listening. In the long run, it actually saves time because you're not being robotic. You're actually learning and everything aligns. We're prepared. We're physicians. We're equipped to handle this. So don't be afraid to just abandon that sterile clinical way of doing things. Just employ active listening. And also share your honesty with patients. Don't scare them, but share your honesty. It also goes a long way in their healing. And I can't overemphasize the need to perform physical examinations. Even when it's a follow-up patient, please do so. Thank you.